In this module, we'll be discussing the features of posterior cerebral artery territory stroke. So this is just a reminder of what we have already seen in the initial modules. You can see the basilar artery, which divides into the posterior cerebral artery. So we'll be looking into the lesion affecting the posterior cerebral artery. Now, posterior cerebral artery is conventionally divided into 4 segments. The easy way to remember is P1, P2, P3 and P4. This is a very simplistic imaging. P1 segment is that one which is between the midbrain, the branch which is segment between the midbrain branch and the thalamus branch. And then P2 is between the thalamus branch and the temporal lobe branch. P3 is between the temporal lobe and the occipital lobe branch. And the P4 is beyond the occipital lobe branch. But this demarcation is only arbitrary. There is no clear anatomical rationale based on which these segments have been actually divided. But sometimes they may ask you a little bit in detail about the posterior cerebral artery segment branch. So this image gives you a better idea about the posterior cerebral artery image. So here it is divided into, you can see here it is divided into P1. P2 is actually a very large segment. So that's why we are dividing it into P2A and P2P. So this is nothing but anterior and posterior part of the second segment. Then you have the P3 segment and the P4 segment. Now P3 and the P4 segment are basically the occipital supply, which is the calcarine artery and the parieto-occipital artery. So that is straightforward. Now P1 segment is again predominantly the thalamo-perforating arteries. You can see here the number 1. So you are able to see here. So this is the branch which goes to the thalamo-perforating artery, which is one of the important perforating artery of the posterior cerebral artery. P2A, you can see that you have the perforating artery to the peduncle of the midbrain. So you can see this 4 very important perforating artery which supplies the cerebral peduncle. Then you have the anterior and the middle temporal artery, which is nothing but this and 7 and 8. Right? So that is so basically it looks into the peduncular supply and the predominant temporal supply. I would say the functional temporal supply. P2P is nothing but the posterior temporal. Right? And then remaining we have already discussed. So this is just an idea about how it is divided into segments. Again, it is more of an academic value. It doesn't have any clear rationale of how things can be actually divided. Okay. So that's the thing you need to really look at. Now, what you need to really look here is the collaterals. There are a lot of collaterals which actually occurs in patients with posterior cerebral artery involvement. Okay. So these posterior cerebral artery involvement have lot of feeders from the middle cerebral artery that we will see in the subsequent slides. So here this image gives you the surface from the undersurface of the brain. So here you have the posterior cerebral artery which is there, and then this gives the anterior temporal branch which we already seen earlier. Then this is the another division, so you call it as the posterior division. So this is the posterior temporal branch. Then you have the calcarine artery. Okay, so this is how it divides there. And we know that already the posterior cerebral artery supplies the predominant part of the base of the brain and the posterior part of the parietal and the entire occipital region. So this is the thing which is supplied by the posterior cerebral artery. Now, the main trunk lesion, you expect it to have a very dense lesion, but that's not the reality. It has variable signs mainly due to the middle cerebral artery territory field, nicely given in the John pattern neurological differential diagnosis. So it may cause a variation. Sometimes it may cause hemiplegia, sometimes hemiparesis, transient hemiparesis, mild sensory deficit, or patchy sensory deficit, transient visual deficit. So the variable signs are very variable due to the MCF field. So main trunk is this area. So here the posterior cerebral artery start. Main trunk is this area. It's very much variable because of the MCF. Perforating artery occlusion, mainly we mean the thalamo-geniculate vessels, and this has more specific abnormality in the form of hemianesthesia and hemianopia because it controls the sensory regions of the thalamus and also the visual field. Therefore, these two are present. But the problem is during recovery from hemianesthesia, they may have a very severe paresthesia. Very severe paresthesia. So that may be very painful and difficult to control with medicines. When the lesion is affecting the upper part of the midbrain, it may cause hemibalismus. So hemibalismus is probably the only involuntary movement which occurs, the flinging upper limb involuntary movement which occurs secondary to a vascular event. So perforating artery has a characteristic involvement. Terminal branch, we all know that hemianopia is there, but with macular sparing because the supply comes from the middle cerebral artery. So these are some of the outline of the localizing part of posterior cerebral artery. So posterior cerebral artery is, we cannot say it is very rare, but it is difficult to diagnose, especially when the deficits are transient. It may come and go off, especially the root, the main trunk, but MRI will have findings of involvement of the vessel.